Welcome to Voices in Value-Based Care. I'm Beth Houck. Thanks for tuning in. The movement to value-based care is revolutionizing how healthcare providers get reimbursed for delivery of care. In this program, we're going to explore stories from the field about how real organizations are dealing with this change. You can follow the show on Twitter at #VoicesInVBC and follow me on Twitter at @BAHouck. On the program today, I have Dr. Michael Sanders of Flagler Hospital in Florida, in sunny, warmer Florida. Dr. Sanders, welcome to the show.
Thank you very much. It's nice to be here, although it's 51 degrees here, as I mentioned earlier. So it's not quite so warm today.
For those of us up north, 51 sounds really good. So I am very excited to talk to you today because I think you have a really interesting story to tell. With very few resources, you managed to orchestrate a significant deployment of artificial intelligence, which ultimately delivered huge cost savings and reduction in length of stay and readmission at your organization. So if that's not a story of surviving in a value-based care world, I don't know what is. So I'm just really excited to talk to you and hear more about that story. So to kick us off, would you mind telling me a little bit about yourself and your organization, perhaps how you went from being a practicing clinician to taking on an initiative such as this?
Sure. Our hospital, Flagler Hospital, is in the oldest city in the United States, Saint Augustine, founded in 1535. Our hospital's been around for 209 years, although I haven't been here that long. Some people think I have. I was teaching, actually, and was going to go into private practice in Annapolis and wound up coming to Saint Augustine for a speaking engagement I had, and my wife and I just kind of fell in love with it. So we decided we're going to move here. So 30-some years ago, we moved to Saint Augustine, and I set up my private practice. I'm a family physician. And about 7 or 8 years ago, the hospital asked me to come aboard as the CMIO. I have a background in computer science. I was a computer scientist before I was a doctor. And I said, no, thank you. I really like what I'm doing. And after 4 or 5 conversations, they finally coaxed me into doing that. And so I came aboard as the CMIO about 7 years ago, and began doing a little research in terms of what medicine was doing around the country. I was just focused on my own private practice and my patients, and came across a number of articles in IHI and several other venues where it looks like about 30 to 35% of healthcare dollars are spent unnecessarily. And most of us kind of understand that with the protectionism that we sometimes see in physicians. But a lot of it is basically wasted because we don't know what the other person is doing. We don't have the coordination. So we began, as we moved toward this value-based care, looking for solutions for how do we get clinical variation under control. And I think a lot of hospitals around the country have struggled with that for a very long time. And so I was sitting at my desk one day, came across an article in one of my informatics journals about Mercy Hospital that had used a company, software I'd never heard of before, IOSD, to actually begin tackling clinical variation. And I became intrigued by what they were doing, so I contacted IOSD. They had not worked with a community hospital. It was mostly a couple of larger health systems. But I asked what we had to do. They explained to me the process, and I felt we could do that. And so we undertook a pilot, and that pilot was pneumonia, which we began in February of this year. We finished the pilot in 9 weeks, and the data we had was a little shocking to us because in our cohorts that IOSD showed us, we had the opportunity to save somewhere around $1,300 in direct variable cost per patient. And we had the opportunity to reduce our readmissions from around 9% down to about 0.9% and reduce mortality and length of stay. All of these were intriguing to us, so I went before the board, presented the pilot, and got the approval to go ahead with the full program. So we began Shortly after that, doing the full analysis, we have roughly 18 cohorts that we're going to try to roll out over the next year and a half. We've done pneumonia in 9 weeks. We turned around and did sepsis, which is much more difficult. We did that in 2 weeks. We have done since then COPD. We just finished heart failure yesterday, and we've rolled out both pneumonia, sepsis, and COPD into production. And we have data from the first quarter of, the last quarter of FY18. For us, that's July 1 to August 30th. And we, in fact, did see a $1,300 reduction in direct variable costs for pneumonia. I don't have the data on the others yet because they weren't started at the time I could have the whole quarter. But we've reduced our length of stay by 2 days with pneumonia. We've reduced readmissions from, I think it was 9% down to, let me just look at the data, to get the right cohort, 0.9%, which is a pretty remarkable reduction.
So when you're describing this and you said, we had to, it took us 2 weeks to roll out pneumonia or whatever you said, a little bit more harder to do sepsis. What do you mean by that? So what goes into that when you're kind of creating a new cohort of disease state to be studying and reducing length of stay on? What goes into that?
Sure. Well, to pick pneumonia first, I picked pneumonia because there are a lot of physicians in our hospital. We have 400 doctors admitting patients to the hospital, and people do things a lot differently. So I thought it was a good test for us to say, okay, one, let's take a look at something where a lot of different people are admitting patients and taking care of them, and let's see what we can get out of this. And secondly, because pneumonia was relatively straightforward, I thought, and so we could take one diagnosis, and we basically extracted the patients from January 2014 through June of 2018, and used that data. We had 1,683 patients, and for us, it was a good learning experience because we didn't want to complicate things too much as we were trying to learn how to use the tool. On the other hand, sepsis is much more difficult. A lot of different variables, a lot of user-defined variables we had to come up with. And it was a much more daunting task because there's a lot of different entries for the sepsis patients. Some people are here in the hospital. They develop sepsis in the hospital. Others present to the ER and they're septic. Others present to the ER and they're septic perhaps the next 24 hours. You don't always know that. And there are a lot of core measures that we need to follow, government guidelines about getting the fluids in at 30 mg per kg in the first 4 hours and so on. So we had a lot of different things to do in sepsis. However, we did it in 2 weeks, which was shocking to us because we took 9 weeks to do pneumonia, but that was our pilot. We were learning how to use the tool. I think we turned around and did COPD in another 2 or 2.5 weeks. We actually had to redo a couple of these because IOSD allows you to have what are called user-defined variables. And for example, we had a user-defined variable. We wanted to see whether the patient was coming from home, from a nursing home, from another hospital, from an ALF or something, so we could see whether there are any differences. We also wanted to know what was their presenting procalcitonin, what was their highest procalcitonin, what was their creatinine at presentation, what was their highest. There are a lot of different variables we collected, and we didn't get it right the first couple of times. We had to reload it. But it only took a day or two for us to get that accomplished. So all in all, we're pretty happy with the way the program is working.
Yeah, I wanted, you were talking about the we and kind of rolling this out. I wanted to get a little bit of sense of what does your team look like when you're kind of doing this initial analysis and reanalysis, which makes complete sense to me that you wouldn't get it right the first time. That's actually part of the magic, right? Like seeing data in one way and then re-looking at it. But then also when you're having to communicate and roll that out to make it be effective, how does that work? Like who's involved? Who do you have to tell? How do they accept it?
Yeah, we had we had a great structure. And I think that we actually had this before we even began with IOSD. When I came aboard as a CMO, I said to my CEO, if I'm going to do this job, what I want to do is establish a group of physicians, one from every department, that we make decisions on how the EMR works, what the workflows are, and what the order sets are, what's included. And so they gave me the okay. I established what we call the PIT crew, Physician IT Group. So our PIT crew meets was every week when we're building the EMR. After a couple of years, we cut back to once every, it's the first and third Wednesday of each month. So the PIT crew is a group of physicians that sit there and we go through all of this analysis. And I got buy-in from the physicians right off the bat when they saw the numbers. And so they spread the word to their colleagues. And we have had really great input from our physicians. And by the way, they're not hospital-owned physicians. These are all private physicians who work for themselves, not the hospital. And one of the nice features that happened during this process was I have to do a presentation at every medical staff meeting on the EMR. I do efficiencies and the things that we're working on, some of the new stuff. And after I do this 15 or 20 minute presentation every board meeting or every medical staff meeting, I usually get about 7 or 8 doctors who come up to me after the meeting and go, "Oh, do you have any idea how horrible this system is? It just is the bane of my existence. It causes me to do so much extra work. Can't we just get rid of this and go back to paper?" And I have to put up with that every board meeting. So after I presented our pneumonia pathway and I asked what we were doing with this new artificial intelligence software, I expected the same kind of arguments at the end of the meeting, people coming up and, "How dare you tell me how to practice medicine?" And so what happened was I had about 7 or 8 physicians that came up to me after the meeting and went, "Wow, this stuff is really cool. Can I come to PIT crew? Can I participate?" And so after that meeting, our PIT crew attendance almost doubled. And so we have people who are not part of the PIT crew who are sitting in and offering suggestions and trying to learn. And it's been a real eye-opening experience for me as we try to get a handle on how do we get this $750 billion of waste out of our healthcare system. We can't do it unless we can control clinical variation. And this is a unique way to do it. And IOSD doesn't like me to talk about the topological map because IOSD is based on a part of mathematics called topological analysis. So topology is a way that you show relationships to the data, and we upload everything that happened to the patient. Every meal, every order for a med, every order for a lab, every lab result, every vital sign, everything. And so IOSD graphs out what happened and exactly when it occurred. Then what we do is we have it cohorted into treatment groups so that we can examine the different treatment groups that are treated similarly. And the nice part about topological data analysis is we don't go into this with any bias. We don't select what do we want to look at. We let the data tell us what to look at. So, for hundreds of years, medicine has worked. We have an idea about what we should be looking at. We decide to do a research project. We decide what data we're going to collect. We do the analysis and find out if there's any bias, and then we try to publish our data. But this turns it on its head. It says, give me all of your data. I'll tell you what significant things that you didn't even know to look at. For example, one of the things that we found in pneumonia is in the ER, when a pneumonia patient presents, if they also have COPD, what we discovered was the sooner you start their nebulizer treatment, the shorter their length of stay, the better the patient's going to do, and the lower their cost. So when they hit the ED, immediately we start them on a nebulizer treatment if they have pneumonia with COPD. And we don't know yet whether it's the nebulizer treatment early or it's the respiratory therapist at the bedside coaching them and helping them. But in any event, getting it started as soon as we can is going to shorten our length of stay, lower our readmissions, and lower our cost. And of course, improve patient care as well. So you can't always know those things when you're making your decision about the clinical trial.
Yeah, there's something you said earlier when you were talking about your adoption rate of, getting people to join your pit crew, and also the notion that you were convinced that they were going to complain about this as much as the adoption of the EHR, but in fact it's done the opposite, which I've been kind of waiting to see this happen too, which is until you can see the benefit of having all of this data in digitized format, it's harder to drive adoption. But once you start to kind of tip over to the other side, where people can see the results of all the efforts of putting this data into these systems, then the adoption starts to go up a little bit more. So I think you're just a really good example of that, which is very interesting. I have to ask, one of the other things when you're describing this, the reduction in clinical variation is obviously what's driving some of your reduction in cost. How is that received? Nobody, from what I understand, no physician really likes to be told, do it this way. It feels a little too cookbook, feels like it's taking away some of their judgment. How was some of the reduction in clinical variation received, and what were the kind of the surprises that the physicians liked?
Sure. There are really a couple of differences here. First of all, we're not using data from some ivory tower institution. We're not saying, okay, well, here's what Mayo did, or here's what Cleveland Clinic did, or here's what Intermountain Health did. Here's their data, so this is what we should do. We're using our own data. So we're using the patient data from our own individual patients and looking at what we have done and trying to make it better. And as I've told each of our physicians, this is not a once and done thing. So when we roll out a care path, which, by the way, IOSI computes for us, we do make adjustments to that based on the evidence of what we know we need to be doing rather than just what happened. But as we roll the care path out every 3 to 6 months, we're going to go back and redo this and say, okay, are there doctors doing something that are getting better results? We should include that in the care path. So it's an iterative process of always making this better. So it's never going to end. It's a constant battle between doing the right thing, because in medicine, what you know today is not necessarily you're going to know tomorrow, because we get better and better and better as we go along. And this is one of those tools that lets you do that. And the second piece of that is that we have an ACO here. The hospital and physicians have joined in the ACO, where the hospital has agreed to share savings back to the physicians. So if we wind up with savings of, for example, in pneumonia, we're projecting for this year, we'll save about $250,000. Some of that money is going to go back to the physicians who participated and helped us save that money. And so that drives them to say, okay, let me get invested. Let me look at what's going on, and let me see if I can make a change in my behavior that will help the community. Now, for me, it's not about the money. It's not about the length of stay. It's about the safety of the patient. And that's where my heart is. And so that's what makes it easy for me to do this, is because at the end of the day, I'm a physician who wants to help people. And if I can do it this way, although it kills me to have left private practice, I love private practice. I love my patients, but I can see this way I'm actually helping more of them.
How do you share all of these stories? How do you share the information about how people are doing and get that information out, as opposed to, outside of your 15-minute presentations at all of these meetings? How else do you share information?
I publish the data for physicians. They see it.
How frequently are they looking at it?
Well, the ACO hasn't done it yet, because we have just finished our first quarter, but the ACO will be getting a monthly report on the what's called the adherence report, which IOSI gives us. So basically it shows all of the patients. Let's take pneumonia. We have about 200 patients, about 250 patients a year. I'm sorry, that's the wrong diagnosis. That was COPD. We have about 280 pneumonia patients a year. So what we will do is we'll publish this report each quarter showing the pneumonia patients that were admitted, the physicians who admitted them, and whether you adhered to the pathway or not, and how you adhered to the pathway. And you can even drill down to look at the individual patients or the things that you didn't comply with. And so we hope by coaching the physicians and helping them, we'll get better adherence, although we've already gotten some, but I'd like it to be perfect. I know it'll never be perfect, but that's what I'd like. And we'll just move the needle closer and closer and closer to what I think is the right thing to do. I'm an old Edward Deming guy. I love the quality improvement. I love the do, test, measure, and see where you are and make adjustments and start it over again. So I just kind of love that methodology.
Where do you go next with it? So is your goal to kind of stop at a certain number of these different diseases and then just watch those for a while? Are you looking to kind of make the list longer? What do you see in your future for this program?
Sure. I have roughly 68 diseases on my list. I'm hoping to get 18 of them done in the first 18 months, one a month for 18 months. And we have, as a matter of fact, we just finished extracting total knee and total hip. So we were going to do those separately, but one thing that's important, I think people need to understand is when we wrote these queries, the SQL queries, we're accessing SCM, our Allscripts database, our enterprise warehouse, our financial system, our surgical system, and our analytics platform. So there are 5 different sources of the data. So we wrote this code that we have 2,500 lines roughly of SQL code to grab this stuff. We parameterize the calls. So when we go from one disease to the next, we simply go to our analytics platform, we get the population that we need, and then we download that, and we are ready for the next one. So that's how we could do this so quickly. And in the process of total knee was supposed to be our next disease we tackled. However, it was straightforward for us to pull both hips and knees. So we did them all at the same time. And then I was able to use IOSD software to cohort out the hips and the knees. So now we have our next 2 ready to go. I've got to do the analysis this weekend, and then it'll be presented to the pit crew. They'll make their decision on what we call the Goldilocks group. We'll do the care pass, and then we'll put it into production. So operationalizing this is very critical, and hospitals need to have that in place before you start. I think we're kind of feeling our way through this, but we've got a pretty good plan, and we're executing it pretty well.
I think what's remarkable about your story is that all of your clinicians are private clinicians. They're not employed by the hospital. So you're
correct.
Mobilizing these pit crews and Goldilocks. That's a new one for me. The Goldilocks crew, all based on these relationships that you've built, and really more of a, I guess, common goal that everybody has adopted towards moving this forward.
You know, I've been in practice for, almost 35 years now. I have never met a physician who didn't want to do the right thing. I've never met one. And so I think if you give them the data and let them trust the data, see where it comes from, I think that physicians will respond. I think the doctors who were not using the order set for pneumonia have seen the data and are now using the order set. I think that physicians basically are good at heart. I think they want to do the right thing. If given the right data and encouragement, I think they'll do the right thing.
That's fantastic. What other any other unintended consequences related to the, almost halo effect that this has had on the organization?
I think that I get stopped by people in the community. Of course, we're a small town, 75,000 people. So people pretty much know me, but I get stopped a lot and asked about what we're doing here with this new fancy AI stuff, how it affects them. And then when they start to see that, oh, this might reduce my length of stay in the hospital, because I didn't want to be there anyway, or it might reduce my cost, or it might prevent unnecessary things from being done. I think people have responded and stopped me and said, "Yeah, this is really cool. Would you come and speak to our group about what you're doing?" And I've done that on 5 or 6 occasions. So I think the community is starting to buy in, and we are in the process of rolling out a I want to say a risk-based contract, but we're getting close to that, where we're actually being able to reduce the cost of healthcare in our county, both for the school board, the hospital itself, which is the largest employer in the county. We have other groups who are interested in what we can do, and when they can see a reduction in cost, then they may just go ahead and sign up for that new program that we're sponsoring, which is almost our own insurance company.
That's fantastic. I mean, when you can then tie it back to the patients and have the patients be excited about it too, I mean, that's really, you're really hitting it out of the park. So we are really close to the end of our time here. Any quick advice for somebody that wants to undertake this initiative?
Roll up your sleeves, get ready to do the work, because you can do it. Now, every hospital will not have someone like me who's got a background in computer science, but you don't need that. But you do need a physician champion. You do need a group like the pit crew that can really make those decisions and share their results with their colleagues and really turn the hospital around. Yeah, I think it's easier for us to do this than it is for some big institution. And typically I've had calls from all over the world, really. I've had a call from a mathematician at Oxford University in England. I've got Johns Hopkins, Harvard, Cleveland Clinic, you name it, they've called to find out what we're doing. They're going to have a more difficult time because they're a large institution. There are a lot of stakeholders that have to be reined in. Small community hospitals like us, I say small, we're bigger than 95% of the hospitals in the country, but we can still do it because we're nimble. And this is like, we created this country a few hundred years ago, and we had the states be sort of the experimenting group for the country. We gave the states certain rights and let them figure out what they needed to do. Some did it well, some not so well. Some regretted what they did. But smaller hospitals can do this. We're the laboratories, I think, of healthcare. And so I see what we're doing is creating the next generation of healthcare, which is we're creating our new textbook with the data. That's
great. Well, I love that the community hospitals can be the laboratory and other ones can learn from you. So thank you so much for your time today. Thank you to our audience for tuning in. You can learn more about the show on the programs page on healthcarenowradio.com and lend your voice to the conversation on Twitter at #VoicesInVBC, and be sure to follow me on Twitter at BA Houck. I'm Beth Houck, bringing you the voices in value-based care you should hear. Until next time, have a great week.